While talking to your patient about their plan of care, you note that they're not really engaged in the conversation. They look like they're not connecting with you. You feel some sort of apathy and you wonder what is going on? Why am I having trouble connecting with my patient?
And the next patient you see is a 1-year-old child coming in who has been fussy and just not acting like themselves. The parents tell you that the child does have sickle cell disease and has been inconsolable, appearing to be uncomfortable. And you wonder, could this be a vaso-occlusive crisis?
In this episode of Critical Decisions in Emergency Medicine, we will talk about trauma-informed care, specifically how to recognize it and how to support patients who have gone through a trauma.
We will also talk about pediatric sickle cell disease, including common complications specific to the pediatric population.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the March 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss the Critical Decisions publication. We usually have 2 lessons that are bread and butter emergency medicine or topics that are cutting edge.
In addition to the 2 lessons, there are also a number of other features, such as the Clinical Pediatrics, the critical cases in Orthopedics and Trauma, as well as additional pearls from our drug and tox boxes.
So for our first lesson, quick on the draw, pediatric sickle cell disease. Thank you to Doctors Gregory Lopez, Alexander Kleinman, Shruti Chandra, and Bernard Lopez on writing this article. You know, Wendy, sickle cell disease is a very important topic, and it can be quite common depending on where you work. We did talk about sickle cell disease in adults in January, and today we're going to talk about it in kids. So first things first, let's start with a refresher on sickle cell disease and other hereditary hemoglobinopathies.
Well, as we know, sickle cell disease is a very prevalent genetic disease worldwide, and it's actually the most frequent inherited hemoglobinopathy in the US. Patients with sickle cell disease have the genetic mutation that causes that hemoglobin S to form, and those with just one abnormal gene have that sickle cell trait, and they're usually asymptomatic. There is a subset of patients with hemoglobin C, and those patients with a combination of hemoglobin S and hemoglobin C have the same but less frequent and severe complications. Now, we don't normally talk much about other hemoglobinopathies, but the one thing to be aware of is that thalassemia, of course, is one of those, and that can actually occur with sickle cell disease. And if there's any history of thalassemia, we should also think about sickle cell disease.
Got it. So what are some complications that we can see from sickle cell disease?
A lot of the complications are similar to the adults, but there are a few that can present quite early in the pediatric population as we start to think about symptom onset. So if you recall, when the fetal hemoglobin starts to decline in the child, then they're going to start having potential manifestations of the disease. And that can be as early as 6 months of age. As we know, vaso-occlusive crisis is a hallmark presentation, and that's usually caused by tissue ischemia or infarction because of that sludging of the sickled and non-sickled red blood cells in the microvasculature. And so when we think about complications related to this particular pathologic process, kids can present with dactylitis as early again as 6 months of age, and that's because of ischemia and infarction of the bone marrow. And that primarily occurs in the hands and feet because that's where hematopoiesis occurs in young children before shifting to more central locations like the arms and legs in older individuals. Another organ that we typically think about with potential complications is the spleen, since it is one of the first organs to suffer effects of this intravascular sickling. This can occur again in children as old as 5 months old. And the biggest complication we think about is acute splenic sequestration, where a number of these RBCs get trapped in the spleen, which leads to obstruction of the venous outflow. And then that, of course, leads to splenomegaly and hypotension, which can be quite life-threatening. Now, with that, we do have to worry about increased risk of infections. And this is reduced with penicillin prophylaxis and vaccines, but we should still have a high suspicion for sepsis in these patients. Other complications we mentioned before in adult patients that are similar in the pediatric population are an increased risk of stroke, as well as gallbladder disease because of this repeat hemolysis that leads to bilirubin gallstone formation. And so in this population, we have to think about choledocholithiasis, cholangitis, and even pancreatitis. And progressive intrahepatic cholestasis is quite rare, but can also be quite dangerous, leading to hepatic ischemia and liver failure.
Quite variable complications. So, what kind of diagnostic tests should be ordered for children with sickle cell disease?
Well, generally, we want to think about our diagnostic workup based on the patient's history and physical. But of course, sometimes these can be a bit vague and limited in children. So we would obtain a CBC and reticulocyte count to really assess for the severity of the child's anemia and bone marrow activity. We know that the white blood cell count can be quite nonspecific, which can be elevated not only in acute infections, but also from stress-related demargination or even increased hematopoiesis. In patients presenting with pulmonary complaints, we would consider a chest x-ray to look for pneumonia and acute chest syndrome. But the big thing is to have a really low threshold for infectious workup, and that can include urine cultures, blood cultures, or even LP because of the child's susceptibility to infections.
Got it. So, we've talked before about how sickle cell disease pain management is essential to help with their symptoms and also the disease process itself. What are the analgesia considerations in children with sickle cell disease?
That's right. Analgesia is definitely very important, and we often use Tylenol or NSAIDs for mild to moderate pain and consider opiates for more severe pain. The one caveat is that codeine was historically used as an oral opiate for vaso-occlusive crisis, but it actually has an increased risk of respiratory depression and death in some children because of variable metabolism. So the American Academy of Pediatrics really recommends avoiding codeine in all pediatric patients.
That's such a great pearl. Well, how about blood transfusions? When do we need to use that in patients with sickle cell disease, specifically pediatric patients?
Well, certainly we consider transfusing if the patient has symptomatic anemia or if their hemoglobin is severely low, like less than 6. And then specific to the sickle cell complications, we would think about exchange transfusions in acute chest syndrome, stroke, intrahepatic cholestasis, acute splenic sequestration, and if they're really, really sick in multi-organ failure. But I would still discuss this with a hematologist to decide the appropriate situation.
Got it. Definitely. If we have access to consult with a pediatric hematologist, then that would be helpful for our patients. So, how about our disposition decisions? Do we need to admit all patients with sickle cell disease?
Good question. Generally, if they're presenting with a complication of sickle cell disease, we should admit them because, again, of a high risk of infection and other complications. But if it is a presentation that is similar to their vaso-occlusive crisis and you're able to achieve adequate pain control, then you can consider discharging them if they are able to go back to a supportive environment and have close follow-up.
Makes sense. Well, thank you, Wendy, for taking the time to review this article. It was definitely a great reminder of a common disease in children, especially in certain locations. Sickle cell disease is a very prevalent genetic disease, and patients can present starting at the age of 6 months with complications from sickle cell. Vaso-occlusive crisis is the hallmark. The earliest manifestation in young kiddos before the age of 2 would be dactylitis, which is a form of that. Another important complication is splenic sequestration, which occurs between the ages of 5 months and 2 years when the sickling happens in the spleen itself. And then, of course, there's an increased risk of infection, risk of stroke, and gallbladder disease. In these patients, we need to make sure to check their CBC and reticulocyte count to assess the severity of anemia. We also need to remember that an elevated white blood cell count is not specific for infection. We can definitely use acetaminophen and NSAIDs for mild to moderate pain and opioids for severe pain. And it's incredibly important to remember to avoid codeine in all pediatric patients. Blood transfusions are needed in symptomatic anemia when there's a significant drop in the hemoglobin or in hemoglobin less than 6, with exchange transfusion used in acute chest syndrome, stroke, intrahepatic cholestasis, acute splenic sequestration, multi-organ failure. And then, of course, if we're able to consult the hematologist, that would be great. Generally, patients coming in with complications of sickle cell disease need to be admitted, But if it's uncomplicated and the pain control has been achieved and the child is older, then the patient may be discharged with outpatient follow-up.
That's right. Thank you for the synopsis, Danya.
Well, keeping up with pediatrics, our Clinical Pediatrics this month is a case of a healthy toddler who comes in with difficulty walking for a week. He has a history of hand, foot, mouth last month and vaccines 10 days ago. Right after the vaccines, he was noted to be crawling when he was, already walking at that point. So his pediatrician started him on steroids. On your assessment, you notice that he has a wide-based gait, but he doesn't have actual weakness in his legs. His blood work shows some leukocytosis, and you're like, well, maybe it's just from the steroids. I don't know about you, Wendy, but I'm just getting more and more confused and more scared the more I read this case.
Yeah, I agree. And we learned that this is actually a case of vertebral osteomyelitis, which is definitely very scary. It is a rare spinal infection in children, usually affecting patients older than 7 years and often involving the lumbosacral spine. And typically we think about hematogenous spread of Staph aureus, and they can present with very nonspecific symptoms like back pain, fever, or limping, which does make, of course, diagnosis challenging. It's even tricky in that the IDSA doesn't even have any guidelines for vertebral osteomyelitis in pediatrics, just adults. Extrapolating from that, we do use MRI to make the diagnosis since x-rays can be quite normal early on. And treatment, of course, includes IV antibiotics. Surgery, thankfully, is rarely needed and really only reserved for severe or unresponsive cases.
Definitely a scary case. Even more pediatrics, our critical image this month is a case of a 3-year-old girl who's coming in with arm pain. She has not been using her arm and she cries with any movement of it. She had influenza 1 week ago with rhinorrhea, nasal congestion, and fever. Her fever returned with the onset of the arm pain. You're concerned about septic joint or osteomyelitis, so you got some labs and you notice that her CRP, ESR, and white count are all elevated. So you think of Cocker's criteria, which accounts for her fever, leukocytosis, ESR, and inability to use the affected limb, and she gets a score of 2. And you say, well, you know what? She has a 40% likelihood of septic arthritis.
Way to go on using Cocker's criteria. Now, this is a case that helps us refresh our memories for the differential diagnosis for spontaneous musculoskeletal pain in young children. We should consider unwitnessed or non-accidental trauma, neoplasia, hemarthrosis from conditions like hemophilia, and inflammatory processes like transient synovitis, and of course, infectious processes like septic joint and osteomyelitis. Now, we just talked about osteomyelitis of the spine. It can, of course, occur in other parts of our skeleton as well. Now, the Cocker criteria can be helpful because it can help us evaluate the risk of septic arthritis versus transient synovitis. In this particular case, you can consider things like an ultrasound, since that can be sensitive for joint effusion. And so if you don't see one, it nearly rules out septic arthritis. And as we mentioned from the prior case, MRI is quite sensitive and specific for osteomyelitis. Now, one thing we want to point out, though, is that even though MRI is quite sensitive, there are other mimickers, such as bone marrow infarction, like in sickle cell disease that we mentioned in the first lesson, or even Ewing sarcoma.
Great review. Now, shifting gears to a completely different topic, our LLSA Literature review is on an article by Hossein El-Hashimi, published in Annals of Emergency Medicine in 2022, entitled Intranasal Topical Application of Tranexamic Acid in Atraumatic Anterior Epistaxis, a double-blind randomized clinical trial.
Epistaxis is definitely common, and thankfully, a great proportion of these stops with just anterior nasal packing. And this particular trial, of course, looked at tranexamic acid as an alternative for when these episodes of epistaxis fail initial measures. They ended up enrolling 240 patients, and those who were in the control group received cotton pledget soaked in phenylephrine and lidocaine, and those in the intervention group received the tranexamic acid along with the phenylephrine and lidocaine. Both received these treatments for 15 minutes, and the addition of tranexamic acid definitely reduced the need for nasal packing the length of stay in the ED, as well as 24-hour rebleeding rates. So I think the study really shows that tranexamic acid is definitely safe and effective and another option for us to managing these cases of anterior epistaxis.
A possible additional intervention when you're dealing with these quite tricky and sick patients. Our critical ECG this month is about hypothermia. A patient was found outside in the winter and their temperature was 30.5 Celsius, which is quite low. Their EKG showed several findings that are consistent and typical for hypothermia. The first is sinus bradycardia. They had also prominent Osborne waves, which are the terminal deflections at the QRS-ST junction that is seen primarily in precordial leads concordant with the QRS complex. They're pathognomonic for hypothermia, especially for core temperatures below 32. And they happen because we have altered ion channel activity due to hypothermia. And switching gears to ortho, our critical cases in orthopedics and trauma is chest pain?
That's what it seems like, because it's a case of a middle-aged man who presents with chest pain and had several ED workups that were negative for ACS. But this time, he looks sick, he's tachycardic, he's hypoxic, and has a new AKI, so you end up ordering a CT to rule out a PE, which you don't find. Instead, you found septic arthritis at the right sternoclavicular joint, an abscess that tracks into the lung in the superior mediastinum, myositis at the pectoral muscle, and an empyema.
Definitely not what you expected. So septic arthritis most often results from hematogenous spread and typically involves a single joint, with the knee being the most commonly affected, followed by the hip and shoulder. Risk factors include immunosuppression, diabetes, joint disease, recent surgery, and IV drug use, though over 20% of cases that occur do not have identifiable risk factors. Staph aureus is the most common, as well as strep pneumo and strep pyogenes. Pseudomonas is a culprit in 10%, especially in patients with IV drug use. Sternoclavicular joint infections are quite rare, accounting for less than 1% of joint infections overall, and may present with chest wall tenderness and swelling, often mimicking other conditions, such as simple cellulitis or an abscess. Complications can include spread to the mediastinum or pleura, just like we saw in this case. The diagnosis involves labs such as CBC, ESR, CRP, blood cultures, imaging, such as CT or MRI, and often joint aspiration, which may be done in the OR. The chest X-ray won't show anything until around 2 weeks from the start of the disease, if then even. Treatment includes antibiotics and surgical management, with en bloc resection preferred due to high failure rates of drainage alone. And keeping up with the ortho theme, also still in that chest trunk area, our critical procedure this month is interscalene nerve block. It's usually used to provide anesthesia to the shoulder and proximal arm. It's great for lacerations, shoulder dislocations, and humeral fractures.
So to perform the procedure itself, definitely refer to the image in this feature. You want to have the patient in a supine position with their head turned away from the side that you're working on. And so if you're working on the right interscalene nerve, then you would want the head turned to the left. Ultrasound is your friend. Identify structures and plan where you're going to actually perform the injection. Of course, we want to identify the carotid artery and the internal jugular veins. And you're going to look for the anterior and middle scalene muscles. Also identify the brachial plexus, which lies between those two muscles. And you want to inject 10 to 20 cc's of your anesthetic. Too much, and you'll end up paralyzing the phrenic nerve.
And I'm assuming that's not what we're trying to do there. Other side effects, other than paralyzing the phrenic nerve, would be allergic reactions, intravascular administration of medication, hematoma formation, infection, and a retained foreign body if the needle breaks. One more thing to keep in mind is that a post-procedure neurovascular examination may be difficult depending on the indication for the nerve block. So keep that in mind. Our second lesson of this issue is deeply rooted, trauma-informed care. Thank you to Doctors Lorado Monda and Kyle Fisher for writing this article.
I definitely didn't learn about this in medical school or residency, so I'm really glad that we have this lesson to discuss this further.
So the actual existence of the topic itself is not new. It's our understanding of it that has recently evolved. Half of the adults in the United States have had at least one traumatic event in their life. And the numbers are higher when we're looking at the worldwide population. Trauma is defined as an event or circumstance resulting in physical harm, emotional harm, and/or life-threatening harm, which can encompass many things. 6% of the US population has PTSD. And that's not just talking about combat, but other trauma, such as community violence, child abuse, sexual abuse, exposure to the criminal justice system, natural disasters, and so on.
That is a very wide definition and involves a lot of people. Now, how does this relate to medical care?
Patients and their families can experience physical and psychological trauma during medical care, such as surviving a heart attack or a stroke, being intubated, or living with an unexplained medical condition. Affected individuals often have anxiety, depression, or anger. They may engage in risky behaviors such as drug use, unsafe sexual practices, violence, and eating disorders to self-medicate their trauma symptoms, and that ultimately leads to chronic diseases.
That makes sense. How does this affect our day-to-day life in the ED?
The effect of trauma can hinder patients from actively participating in their own care in the ED during history taking, physical examination, procedures, workups. Patients' abilities to understand a medical diagnosis or a recommended intervention can also be hampered, leading to inadequate care or delays in providing quality care. And this is what trauma-informed care means. It's an approach to patient care that recognizes how that exposure to trauma can have a profound impact at the bedside.
I see. What are some core principles behind trauma-informed care?
There are quite a few. One is realizing the impact of trauma and understanding the paths to recovery. Two is recognizing the signs and symptoms of trauma in patients, families, and staff. Third is responding by incorporating knowledge about trauma into policies, procedures, and practices. And fourth would be avoiding re-traumatization.
Got it. Are there any particular approaches to implementing trauma-informed care?
There are 6 guiding factors to administering trauma-informed care. The first is empowerment, voice and choice, which is autonomy in making decisions and voicing discomfort. The second is peer support, whether friends and family or members of a professional organization. The third is collaboration and mutuality. The fourth is safety, both physical and emotional, to prevent re-traumatization and increasing the safety of the healthcare team. The fifth is trust and transparency, including acknowledgement of procedures, examinations that may re-traumatize patients. The sixth is cultural, historical, and gender issues, which means recognizing that marginalized groups are at a higher risk. There's a fantastic table in the article, Table 1, that summarizes these guiding factors quite well.
So how does a history of trauma affect how patients present?
So a history of trauma can have profound and often unexpected effects at the bedside. Patients in this situation may show signs and symptoms of trauma in addition to their presenting symptoms, such as argumentative behavior, withdrawal, apathy, irritability, hostility, and so on. There's a table in the article that goes into details into these presenting symptoms with multiple, quite insightful examples.
I see. Now, for us as clinicians, how do we address this at the bedside?
Incorporating the 6 guiding factors that we talked about earlier is essential. We need to have a clear introduction. We need to use an interpreter if needed, avoid stigmatizing language, and invite questions often. We can also employ the teach-back method to ensure understanding. We need to understand that agitation and other behaviors may be a result of trauma and focus on de-escalating the situation rather than get angry at the patient. The article does give us a fantastic reminder of the 10 domains of de-escalation in Table 3.
Well, great resources in the lesson for sure. What about screening and assessing for trauma in the ED?
Well, we can utilize formal trauma screening programs that are conducted by individuals with minimal training in this specific matter, such as our own clinical staff. We can screen for trauma-related symptoms, depressive or dissociative symptoms, mental disorders, characteristics of a specific trauma type, substance misuse, social support, availability of resources, risk for self-harm, suicide, violence, And there are many, many specific tools that have been developed, and they may be self-administered or clinician-administered. That said, sometimes a simple question, such as, have you ever experienced trauma in previous medical or other life encounters? Or, have you experienced anything that makes seeing a doctor difficult or scary for you? Can be used as well, noting that the tone and empathy in which you say those questions are more likely to make it perceived in the intent that it is meant. Individuals who screen positive will then need to be fully assessed by professionals who are well-trained and knowledgeable, such as psychiatrists or counselors.
That is really helpful. What about our role in facilitating outpatient trauma-informed care?
Hospital-based violence intervention programs for survivors of community violence, trauma recovery centers for survivors of sexual violence, peer recovery programs for substance use or mental illness, local healthcare for homeless patients, those are all great resources in the outpatient care. Patients with mental health disorders who require assistance can also be referred to SAMHSA's helpline and online locator, the Suicide and Crisis Lifeline, which is 988, or any other mental health resource, helpline, or online locator.
Got it. Now, I imagine there are certainly challenges to providing trauma-informed care. Do you have any tips on how we can overcome these?
You're absolutely right. Some institutions lack the resources or infrastructure to create advanced systems of trauma-informed care. Namely, the dedicated staff and funding would not be available. Another challenge is that patients may be reluctant to disclose a history of trauma or trauma effects, either because they are afraid of the perpetrator or because they don't even recognize the trauma themselves. Finally, the logistics of care in the ED can make this quite challenging. The time limitations, the urgency of the presenting condition, the inability to follow up with patients after the visit, or the patient's hesitancy to confide in unfamiliar physicians can make this even more complicated.
That makes sense. Now let's talk a little bit about patients with mental illnesses. Are there any special considerations when we're trying to implement trauma-informed care in this population?
Well, remember that the relationship between trauma and mental illness is cyclical. Mental illness increases the risk of traumatic experiences, and traumatic experiences lead to more severe symptoms of mental illness. Individuals with severe mental illness have often had traumatic experiences in healthcare settings as well, such as being physically restrained. For these patients, going to the emergency department for care can evoke symptoms of traumatic stress.
Okay. What about special considerations for survivors of sexual violence?
There are many things that we can do to help support these patients when they present to the emergency department for care. And the article goes into a lot of details about that. Simple examples are attending to draping and modesty, staying within eyesight during the procedure, using clinical words instead of slang, such as the gurney or the stretcher instead of the bed, being efficient and being polite. Definitely worth a review.
Well, thank you, Danya, for taking us through this lesson. I want to definitely thank the authors for writing this very important lesson, as these are definitely principles we should try and integrate into our practices so that we can better support these patients. As we mentioned, there are a lot of great resources within the lesson that outline some of the principles of trauma-informed care, as well as factors in administration of trauma-informed care, as well as ways to de-escalate. But a few pearls that I took away from this lesson is that it starts by us recognizing that this is an important factor in how our patients may present and experience their medical care, as well as the potential subsequent effects of receiving medical care. And we can screen for it, whether formally or even with a question like, have you ever experienced trauma in your previous medical or other life encounters, to better understand patients particularly at risk for this. And in our particular encounters, empowering the patient in their autonomy in making decisions, avoiding stigmatizing language, creating really that environment of trust and transparency are all some techniques that I think that we can better, again, support these patients.
Thank you, Wendy, for this summary. Our drug box this month is digoxin for rapid atrial fibrillation. I will interrupt here and say, don't know about you, but I am personally a fan.
Me too.
I think that's why we're friends. Well, one of the reasons we're friends.
We're the Jackson buddies. Yes, indeed. It's a very good medication to use in rapid AFib, especially in patients with heart failure who have quite tenuous hemodynamics because, of course, of the positive inotropic effect. Oftentimes, we also think about it when beta blockers and calcium channel blockers are ineffective, so later down the treatment algorithm. Part of it is because it does have a slower onset than other medications, and a few other conditions where it would not be appropriate would be in pre-excitation due to accessory pathways because the AV nodal blockade can then trigger ventricular tachyarrhythmia. If you do give it, you want to give an IV load of 8 to 12 mics per kilo, and that's typically about 600 to 1,000 micrograms. And this is given over 12 hours, starting with 50% of the dose as a bolus, followed by 25% of the load every 6 hours subsequently. Generally, you'll see the effect with the first load within 1 to 4 hours. And if you do achieve good heart rate control, then you don't need to give the subsequent loads.
Great reminder of an oldie but goodie. Last but not least, our Tox Box this month is trichloroethylene toxicity. It's an organic halogenated solvent previously used as a general anesthetic or analgesic. The human use was banned in 1977, but it's still used in commercial application for refrigeration, metal degreasing, and less so in dry cleaning. Toxicity occurs from heat or alkali-promoted decomposition. It can cause neuronal degeneration and demyelination, and also hepatic and renal toxicity. Clinical symptoms include confusion, dizziness, sensory motor deficits, dysrhythmias, nausea and vomiting, exfoliative dermatitis, rhabdomyolysis, and disulfiram-like reaction with ethanol. In patients with suspected toxicity, we need to obtain LFTs, renal function, an ECG, and a chest X-ray to evaluate for aspiration. We can obtain urine or blood levels to confirm the diagnosis, but I'm guessing that's not an ED thing. We also need to decontaminate the patient by removing the clothing and irrigate them if there's any dermal or ocular exposure. If they're symptomatic, or if we are concerned that they've ingested 20 mLs or more, then these patients need to be admitted.
That's a good thing that it is banned from a lot of uses, but I guess something we still have to be aware of.
Definitely. Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication always informative, often enlightening, and never boring.
Reach out to us on social media. My handle on Instagram and Threads is at Dr. Danya Khoujah, and on Blue Sky is Dr. Danya.
Mine on Instagram is at Dr. Wendy Chang.
And until next month,
bye-bye.